Good afternoon, everyone. I welcome you all to this clinical grand round in the Department of Pulmonary Critical Care and Sleep Medicine. Today's topic is pertinent to almost every specialty because in AIIMS there are so many ICUs and even in emergency department, many patients are requiring mechanical ventilation. And everybody who is caring these patients will agree with me that weaning is the most important step as far as the management of these patients is concerned. So today we will discuss little in detail about what is weaning and something about difficult weaning, prolonged weaning, and what is the role of different modalities, what are the assessments, and we will also share some of our experience from the department. So to start with the proceeding, I will invite Professor Anant Mohan, who is start with the introduction.
Thank you, Vijay. Good afternoon, everybody. And as already mentioned, we choose this topic because in the last 2-3 decades, we have seen significant advances in critical care, ICU management all over the world, in fact, whether it is because of technology, expertise, or better tools for monitoring, ventilation, whatever be the reason, but ICU care has substantially kind of taken off. Now, one of the important things is mechanical ventilation, and whenever, of course, it is a life-saving intervention, no doubt about it. But at the same time, it is also a double-edged sword, and that is why we should know when to liberate a person from the ventilation, and that is what is known as weaning or liberation from ventilation, whatever we call it. So basically, how do we define? The definition of weaning or liberation from a ventilator can be something which is very general. It is basically the phenomenon by which we gradually withdraw a person from mechanical ventilation, and at the same time we allow that person to resume the spontaneous breathing. So because that is what the ultimate goal and ultimate aim is, to have the patient back to his normal physiological self. Now, in this, the important part is the gradual withdrawal. So, this is something which we have to be very careful and very mindful of, that it should not be something which is taken by knee-jerk reactions, not something which is taken just by somebody objective whims and fancies, but there are certain criteria to decide how to withdraw, and it should be a gradual process with very close monitoring. So that is why it is also known as liberation. So both the things can be used. Now, we have to go one step back, and weaning is from invasive mechanical ventilation. And if we see, like we mentioned about in the last 20-25 years, the trends of invasive for putting a person on an invasive mechanical ventilator has actually increased. If you can see this white line from the early 1990s to 2009, around about 15-20 years, this is how the number of cases per set of population and the mechanical ventilation has increased. That is where it is basically it is plus minus for COPD, plus minus for heart failure, and heart failure it is actually gone down, and the reasons for that is mostly because of more and more use of the NIV ventilator as well. So why is basically weaning important? Weaning is important because the mechanical ventilation have got their own complications, especially if they are prolonged beyond a certain limit of time, beyond what is required for that particular patient. And this is just one very broad kind of a list which lists out the complications which are associated with mechanical ventilation. And as we can see anatomically, if we can subdivide, the problems may happen at the upper airways or the mouth because of various problems like pressure or oral sores, ulceration of the lip because of the endotracheal tube, and the pressures, injury to the tooth may happen because we are kind of intubating, there may be frequent re-intubations, etc. Injury to the tooth may happen, necrosis to the nasal airways, erosions of the hard palate because of repeated mechanical friction. So many other problems are there. And similarly, more importantly, in the larynx and in the lower part are the other important complications like glottic edema, that is very life-threatening and something which has been we have to be very mindful of. Sometimes hemorrhage, granuloma formation may happen wherever there is a kind of foreign body for a long time. Granulomas may form, and ultimately laryngeal ulcerations as well. In the trachea, again, a host of complications ranging from edema, some mucosal hemorrhage, granuloma formation, ulceration, necrosis. So basically, it is the things related to the endotracheal tube and the foreign body which is there, and tracheomalacic kind of mucosa. Sometimes tracheoesophageal fistulas have been known and other problems as well. Ultimately, in the lung, because of the ventilation and the endotracheal tube being in per se, ventilator-associated pneumonia is a life-threatening and very kind of major complication. That is something which we are all dealing with. Aspiration pneumonia and sometimes collapse of the lungs may also happen. So these are all the problems which may happen, because of which early weaning from a ventilation is extremely important. So there are certain questions to be answered, and in fact there are many more questions than answers, but some of the questions are these ones, and in the next 30-40 minutes our colleagues will try to answer some of these questions for you. So when we have put the patient on a ventilator, the first thing, and we have to keep on seeing on a daily basis, is the patient ready for taking off the ventilator? If not, then we have to see why not. So we have to try and find the reasons for it, and we have to take care of those reasons. The third question would be how to do it. So what are the methods by which a patient should be weaned off a ventilator? And you will see subsequently there are various ways, and we'll see the pros and cons of each of them, and if there is any better way out of them. Then how to assess if our weaning, whatever we have tried, if the weaning is successful or not successful. Who are the people who are likely to succeed? Who are the people who are likely to fail? Because in those, probably we should not be trying to wean at that time. And then ultimately how to prevent failure of the whole process or the whole exercise that we have done. And because of all these questions, now all over the world, many societies are formulating their own guidelines, and these are just to quote a few of them from this is basically from the ERS a couple of years back, and then very recently from the Korean Society as well, and there are many more. So they've all tried to formulate their own guidelines about how to do the things and when to do it. And this basically is the whole process of weaning. Once we have acute respiratory failure, after admission, we have to basically assess the readiness to wean. And there are various methods, one of which is a spontaneous breathing trial. Ultimately, go for extubation, but monitor very closely, because there is definitely a chance of reintubation. And once all that is achieved, then the person can go home. So with this, I'll close here, and I think after that, basically, this one thing is there, that basically one should not go in for an unplanned extubation, because that happens, and almost half of them are able to be successfully weaned off, and they do not require, but at least about half do require a reintubation. So that is something that we have to keep in mind. So I'll skip all these things, is not required all these. I think I'll go straight to the basically the weaning and other parts of the thing, which will be kind of taken subsequently by my other colleagues. And this is basically the outline. Thank you.
Thank you, sir, and good evening, everyone. My name is Dr. Tejas, and I will be taking the part on how to assess the readiness for weaning. So why do we need to assess readiness for weaning? Basically, when we have protocolized liberation from mechanical ventilation, that can reduce the time of ventilator and ICU stay. And basically, this protocolized liberation is of 3 steps. The first step is the readiness testing. The second is the actual weaning or the SBT. And the third is the extubation and preventing the reintubation, as sir has highlighted. And we need to do it in a protocolized way, because if we do too early weaning, then that can lead to weaning failure, and a delayed weaning can lead to the complications which had been enumerated by sir in the previous presentation. And the problem is that if we don't do a protocolized liberation, then the physicians often underestimate the patient's ability to breathe free from invasive mechanical ventilation. So that is why a certain set of clinical criteria is necessary to objectively guide us to tell whether a patient is actually ready now for weaning. And the important clinical criteria based on the various studies which have been collated together are as follows. First of all, there should be an improvement of the underlying cause of respiratory failure, the reason why the patient was put on invasive mechanical ventilation in the first place. The second is patient should now have adequate oxygenation, which is usually described as a requirement of less than 40% FiO2 and a PEEP of less than equal to 5, with which the patient can maintain a saturation of above 90%. The third is that the arterial pH should be nearly in the normal range, above 7.25. Fourth is the patient should be hemodynamically stable, neither hypotensive nor hypertensive, with low dose or no vasopressors. And finally, the patient should be capable of spontaneous respiration. So these criteria have come from various studies. One of them is this awakening and breathing control trial, in which basically protocolized liberation was done in 2 steps. First is the patient was given daily interruption in sedation, and then they were screened for SBT using adequate oxygenation, hemodynamic stability, and ability to initiate inspiration. If based on these screening criteria, the patient went on for a SBT or a weaning trial, then more than 50% of the patients were successful in that trial and went on to be extubated. And even those who did not tolerate the SBT, they do not usually have complication, because the complications are rare for SBT after satisfying the readiness criteria. And the benefit was that when we did this in a protocolized manner, the patients in the intervention arm had shorter duration of mechanical ventilation and ICU stay reduced by almost 3 days. Additional optional criteria for testing readiness are hemoglobin of should be above 7 gram per deciliter. The core temperature should be in the normal range. Patient should not have fever, and they should ideally be awake or arousable. Now, normally we go for readiness testing based on the aforementioned criteria, the ones which I have already mentioned. But sometimes when we are not sure, there is uncertainty based on these criteria whether the patient is ready to wean or not. Maybe one of the predictors is not satisfying or is out of proportion to the others. So in that case, we may consider using certain weaning predictors. So the most popular weaning predictor is the rapid shallow breathing index. So how is this calculated? For this, basically we use a handheld spirometer which is attached to the ET tube when the patient is breathing room air. However, this is often cumbersome and not available in our ICU. So alternatively, you can put the patient on pressure support, stop the sedation, make sure patient is awake, and then set the pressure support and the PEEP to 0 for 1 minute, and then measure the minute ventilation from the ventilator. The respiratory rate should be corroborated manually, because sometimes the ventilator may not detect some respiratory efforts which do not get converted into breaths. And then we divide the respiratory rate by the tidal volume, and normally the respiratory rate should be low and the tidal volume should be, or the minute ventilation should be, higher. So that means this fraction should be smaller in the ideal scenario. So less than 105 means you can initiate weaning. More than 105 means do not initiate breathing. So generally this kind of an index is having a very high sensitivity for picking up patients who can be weaned, but does not have a very high specificity. What this means in other words is that if it is negative, meaning if the value is more than 105, that will be better at predicting weaning failure. But if the value is less than 105, that may not be so good at predicting weaning success. So still patient may fail the weaning trial. However, routine use of the RSBI is not indicated, because if you use RSBI routinely in addition to the clinical criteria, that has actually been found to increase the amount of time required to wean the patient from the ventilator. So routinely we just go for the clinical criteria and reserve the RSBI for cases when uncertainty exists. Now, after you have done the weaning testing, readiness testing, the next step is to actually go for the spontaneous breathing trial. And to discuss about that, I would like to invite Dr. Saurabh Mehta.
So good afternoon, everyone. So now we have seen that a patient who is to be weaned has to fulfill the criteria that he is ready to be weaned. So there are two things which we need to understand. There is something called a spontaneous awakening trial, and there is something called a spontaneous breathing trial. So that means every day patient should be given both. One is the awakening, that means a sedation-free interval should be given to everyone so that patient becomes awake. And once the patient is awake, then we assess for the readiness. So once readiness has been assessed, the patient is ready for weaning, then we go ahead with the trial, that how do we wean these patients, and that's what I am going to discuss. So there are different methods of weaning patients. So most common method is the manual weaning, which we all use in our ICU. However, there are automated weaning protocols and ventilators are available. Also, many a times weaning is done, the patients of specifically of COPD, they are extubated without an SPT with extubated to a non-invasive ventilation. So this is also one way to extubate patients who have chronic obstructive lung disease, but most common way to use weaning is the manual weaning. So how do we do manual weaning? So there are basically three ways to do manual weaning. Out of these, daily SBT is actually the right and the most common and most scientific method to do a daily SBT weaning. How do we give a daily SBT? There are various ways which I will discuss in detail, but one is whether use a T-piece, that means you disconnect the ventilator and you put the patient on low flow oxygen, or second is very smooth on the ventilator. The other ways which were used previously for manual weaning were progressive reduction in a pressure support. Supposedly you have a patient who is on a assist control mode, you put them on a higher pressure support and you gradually reduce the pressure support. So that was one way to do a weaning. Another way was the progressive reduction in a respiratory rate. So patient who was on a controlled assist control mode was shifted to a SIMV mode, and therefore there was gradual reduction in the respiratory rate with time, so that you bring the patient to breathe on his own rather than on the controlled ventilation. However, studies have shown that daily SBT is better than these two methods. So as of now, most ICUs use a daily SBT trial after readiness of weaning for weaning these patients. What is automated weaning? Automated weaning there are some specific softwares which are patented by different companies, predominantly from the Hamilton, that they are computer-driven closed-loop proprietary PSV weaning. And what happens that for manual weaning, you need to train your staff, your nurses, your respiratory technicians. They should be ready to do this. While in automated weaning, it is less labor-intensive, but it is more costly. So it is not to be, it cannot be tailored to the individual patient. So most ICUs still use manual weaning over automated weaning. So when we look at the data regarding the manual versus automated weaning, so this was the weaning study which was published in 2013, in which 92 patients were enrolled, and mechanical ventilation duration was similar in automated weaning and protocolized manual weaning. So what Tejas discussed about the weaning, that there are two ways. In manual also, one is physician directed weaning, one is protocolized weaning. That means if I feel patient is ready to be weaned but the other physician does not, so that should not be happening. Every ICU should have a protocolized weaning, that these are the criteria. Once patient fulfills this, they need to be given an SVT, whether I am on round or somebody else is on round. That means protocol has to be followed for weaning, rather than it should not be individual doctor or nurse specific. Now, when we talk about the daily SVT versus other methods of weaning, which I discussed previously, so it has been shown that one daily SVT reduces the time of weaning as compared to all other methods. So now we will discuss a little detail about how do we give once daily spontaneous breathing trial. So there are mainly three ways you can give a spontaneous breathing trial. One is TPs, that means you disconnect and you put the patient on oxygen. So this used to be one of the commonest ways of giving a trial in patients during weaning. The other two ways are low level of CPAP, that means you put the patient only on a CPAP of 5 to 7. The other way is that you put the patient on an inspiratory pressure support of 5 to 8. So there are these three ways in which a spontaneous breathing trial can be given. So if we talk about in the low pressure support, you put a PEEP of 0 to 5 and a pressure support to 5 to 7, and a 5 to is less than 0.4. If we compare TPs versus other methods, what happens? The TPs, you have to monitor the patient manually, because you are disconnected from the ventilator, your ventilator does not show anything. So these methods are better than TPs in view of monitoring and ease of monitoring, because your ventilator will give you the respiratory rate, your ventilator will give you the tidal volume, 10-minute ventilation, and it will also have alarms and the backup for apnea ventilation. If patient does not breathe, it will help you to pick that up early. Usual duration of daily SPTs is 30 minutes to 2 hours. So there have been data which has shown that they are actually same. So this was a large study which was published in 2019, which looked at effect of pressure support versus TPs ventilation on SBTs in patients who require mechanical ventilation. So they compared 30 minutes of pressure support ventilation versus 2 hours of TPs, and they found that 82.3% patients were successfully extubated in the pressure support group as compared to 72.4% in the TPs trial. So with this, there has been proven that 30 minutes of pressure support spontaneous breathing trial is better to be used in individuals And the 2017 guidelines for the liberation from mechanical ventilation have suggested, and this is very important, that for acutely hospitalized patients who are ventilated more than 24 hours, it is suggested that initial XPT should be conducted with a inspiratory pressure augmentation rather than without. That means you should prefer doing a pressure support for SBT rather than a T-piece or a CPAP. Because I still see in our hospital also many ICUs, you still use T-piece or CPAP as preferred mode, but inspiratory pressure augmentation is the preferred mode for patients during spontaneous breathing trial. Now, another thing which I've been discussing is the variation in practice. So, if you in the AIIMS, I think we have like 20-30 ICUs. So, there has been a lot of variation in the ICUs. So, this study looked at the what is the variability in ICUs. So, this had patients from 1,868 patients from ICUs in United States, Canada, Europe, India, Australia, and New Zealand. And what they found that 22% patients were directly extubated, 50% were extubated after SBT, 8 patients, 8% directly tracheostomized, and 20% nearly died before weaning. The protocolized readiness screening was followed in 83% in US, 56% in Canada, and 70% of Indian ICUs. And commonest frequency of readiness screening was once daily in almost 75% of Indian ICUs. So that means there is a lot of variability between countries, between centers, and intra-center variabilities also exist. So how do we assess? Once we have put a patient on a spontaneous breathing trial, we put them for a 30 minutes of pressure support ventilation. Now, how do we monitor and how do we decide that they have successfully passed a spontaneous breathing trial? So we need to monitor certain things. What are the monitoring? That is the clinical signs of respiratory distress, mental status, vital signs, ventilatory parameters, specifically the tidal volume and the minute ventilation. And we need to perform an arterial blood gas at the end of spontaneous breathing trial, specifically for patients who have COPD or a hypercapnic respiratory failure. Also, a continuous ECG should be monitored during spontaneous breathing trial for any ischemia during the effort. So how do we define SBT success? So there should be subjective comfort, hemodynamic stability, adequate gas exchange, and respiratory pattern of the patient. So for subjectively, if you see a patient like this, that means he is in distress. So what are the things? If patient has anxiety and agitation, depressed mental status, diaphoresis, cyanosis, increased accessory muscle activity, facial signs of distress, or thoracoabdominal paradox, it tells you the patient is failing SBT. The objective criteria, that means on ABG you need to see that the oxygenation is maintained. The PaCO2 is if it goes more than 50 or there is an increase of 8 to 10 in PaCO2 or pH falls by 0.07 units, that tells you the patient is failing SBT. Other parameters are the ventilator, that means the FR by VT, that was the index. If it goes more than 105 or respiratory rate goes beyond more than 35 or increased by 50%, that tells you the patient is failing SBT. This is important for all residents who work in ICU, that you need to remember these criteria whenever you put a patient on a spontaneous breathing trial. In the cardiovascular system, if there is tachycardia, there is hypertension or hypotension or development of arrhythmia during a spontaneous breathing trial, that tells you the patient has actually failed SBT. So once you have given SBT, patient has successfully weaned. So what is the frequency that they will actually be getting weaned? So what I have told is simple weaning. You give one SBT, patient gets extubated or patient gets weaned. That happens in around 50 to 75% of patients. However, a significant proportion will be difficult to wean, and Dr. Vijay will discuss these patients, how do we manage this group of patients, and some proportion of patients will require a prolonged weaning. That means they would require a weaning beyond 7 days of mechanical ventilation. So once we have discussed, so there are two ways. One is weaning. So what we have discussed till now is weaning. Now comes the step of extubation. Weaning means the patient is able to breathe, but extubation means we need to remove the endotracheal tube. So what are the criteria which we need to see before we extubate a patient? That means patient should be alert and should have a good muscle function. So this can be tested by ability to lift the head off the bed for 5 seconds. If patient is able to lift his head, that means muscle power is adequate. Patient should have an adequate cough reflex and must not be requiring very frequent suctioning because of secretions. Also, patient should have adequate airway patency, that is tested by cuff leak test. So cuff leak test is important for not everyone, but for patients who have a high risk of weaning failure. So how do we perform a cuff leak test? What is cuff leak test? That you have a patient who has been intubated, has an endotracheal tube in place, and now has this cuff. So what we want to do, we deflate this cuff and we see how much air is leaking. So we look at the ventilator, that what is the leak happening in the ventilator after cuff has been deflated. If this leak is less than 100 ml or less than 10 to 15%, that means there is inadequate leak. What it tells me that this area is actually edematous and patient will not be able to breathe after tube has been removed. So this is important for patients who are at prolonged ventilation or who have history of previous laryngeal edema or stridor, or who have multiple other factors which I will discuss. In them, a cuff leak test should be performed before attempting a extubation. And those who fail actually a cuff leak test, we need to give them steroids for 24 hours prior to extubation to reduce the airway edema to improve their chances of successful extubation. So what are the patients who are at risk of post-extubation failure? Elderly, those who fail more than one trial, chronic heart failure, those who have hypercapnia at extubation, those who have multiple comorbidities, poor cuff reflex, or obese individuals. Now, re-intubation, one important thing is that post-extubation respiratory failure is a truth in ICUs and it should be recognized early. So how do we recognize? These are the criteria which will tell you now patient who has been extubated is now failing and will require re-intubation, and this will be discussed in detail by Dr. Pawan in the next discussion. So I'll request Dr. Vijay to now go ahead with the difficult or the prolonged.
Thank you, Saurabh. So difficult or prolonged weaning, as already defined, that the patient who failed after first HBT or patient who are requiring re-intubation. So this is usually seen in approximately 20 to 25% of patient difficult weaning, and if we add prolonged also, this number can be little more. In our experience in our ICU, in one study we found that approximately 60% of the patients are extubated with first trial itself. So difficult or prolonged weaning is important because once the weaning fails, there is lots of adverse outcome associated with this. The person will require re-institution of invasive mechanical ventilation. There will be more stay in ICU or hospital. There will be additional cost of care, and approximately 50% of patients who are having prolonged or difficult weaning, they may be still dependent on invasive mechanical ventilation. And also there is a mortality among these patients, which is tuning around 40 to 75% of patients. So to understand the pathophysiology of the difficult or prolonged weaning, we should understand that the respiratory drive, neurotransmission, and the respiratory muscle load and capacity, these are required in optimum amount. So anything which is impairing this, for example, anything which is impairing the capacity of respiratory muscles because of obesity or because of atelectasis or bronchospasm or secretion, which are adding to the resistive forces. Similarly, if the brain is not functioning properly because of maybe neuromuscular disorder or because of excessive use of sedatives or neuroparalytics or head injury or CVA, these will reduce the respiratory drive. Similarly, there may be other conditions where there can be problem with neurotransmission, for example, cranial nerve injury, maybe in post-operative patients, or some neuromuscular drugs. So what happens when there is a respiratory muscle load is increased? It will increase the work of breathing, and this is usually seen in patients who are having lots of secretion, bronchospasm. Their patient can have elastic load in the form of atelectasis, maybe pulmonary fibrosis, cellular edema, chest wall dysfunction. All this will lead to increased elastic load. And similarly, some patient can have the air trapping leading to autopep, which will also increase the work of breathing, and this can contribute the prolonged or failed weaning. Respiratory muscle drive, as I already discussed, and similarly muscle capacity. So the last one is very important. We usually suspect that this patient can have a neuromuscular weakness, which is commonly acronymized as SINMA, but it's very difficult to assess in the ICU setting. The problem is because many times it is not suspected, but even if it is suspected, the methods of assessments are having very limited kind of information. For example, if you want to assess the power, many of patients in ICU will be in altered sensorium, or they will be sedated, or they will be receiving some neuromuscular drugs. So all these tests will require a patient who is fully awake, fully cooperative, and he or she should understand what we are asking for. And all these are blunted by use of sedative or neuroparalytics. So it is very, very difficult. And sometimes we can also assess the muscle function. Maybe we can do the physiological study but for that patient will require shifting out of ICU, which is very difficult. Also, we can do some kind of a investigation, for example, maybe CT scan, which can assess the muscle function, or maybe fluoroscopy, which can assess the diaphragm function. But again, it is very difficult to do. In this setting, I think ultrasonography, which is nowadays available in almost each and all ICUs, can be very handy. So this is the images which have shown that you can easily assess the muscle. This is the muscle thickness you can assess, either it may be arm or thigh, which can easily give you the status that what is the thickness today, and we can measure it serially. And good thing is we can measure it easily and it is quite reliable. And there are multiple studies which have shown that the thickness assessed by ultrasonography correlates well with the thickness measured by either CT scan, MRI or DEXA scan. So this is very good modality, and I recommend that all of the people who are working in ICU or maybe the setting where a critical illness myoneuropathy is suspected, ultrasonography can be done there. Similarly, we have also checked that there is no intra or intra-observer variability if we assess this kind of thickness using ultrasonography. Also, we find that if we assess the thickness over time in the ICU, these patients have shown that the thickness decreases over time. In one study, this was published some time back, which included 70 patients, and we did ultrasonography of the muscles on day 1, 3, 5, 7, 10 and 14 days. And we have found that each day the muscle thickness was going down. That is not unsurprising, but the good thing was, or the surprising was, the decline in muscle thickness was associated with adverse outcome. The patient who had more thickness decline, they have more prolonged ICU stay, prolonged hospital stay. Even there was more time spent on mechanical ventilation. I have not presented data regarding the weaning success or failure, but there was some patient who have failed weaning and they have lost more muscle as compared to the patient who had successfully passed the weaning trial. Similarly, diaphragm is very important muscle, which is, I think, the sole muscle of respiration, which is the actively participating. And there are multiple studies which have shown that diaphragm dysfunction is very common in patients with mechanical ventilation. And there is one study which has shown that within few hours of mechanical ventilation, patients start showing the evidence of diaphragm dysfunction. But again, clinically, it is very, very difficult to assess the diaphragm weakness in ICU because this muscle is totally closed in the thoracic and abdominal cavity. So it is very, very difficult. Again, ultrasonography have revolutionized the assessment of diaphragm in these patients, and we can assess various parameters using diaphragm. For example, we can see the diaphragm here, then we can assess the diaphragm thickness, and expiration, inspiration, and we can also assess the excursion. So these are very simple things which can be done bedside and which can be repeated also. And we have again shown that this diaphragm thickness can easily be measured and is very, very reliable, reproducible, and can be easily measured in ICU. In one study which we did during COVID, which have shown that ultrasonography we do on diaphragm, that has shown that there is a definite decline in the diaphragm parameters, including excursion, the diaphragm thickness fraction, as well as thickness. And we found that as the patient improves, the thickness fraction keep on improving. So again, showing that the ultrasonography is very useful modality to assess the neuromuscular weakness or cinema components. So in the weaning, this diaphragm thickness or diaphragm function has been commonly assessed by the ultrasonography, and multiple studies have shown that the diaphragm excursion, which if less than 10 mm in one study, in another study 12.6 millimeter, if less than that, is associated with the prolonged weaning. Similarly, diaphragm thickness fraction, different studies have used different cutoffs, but again, if we use the diaphragm thickness fraction, it can predict the weaning failure or success of SBT or extubation failure. Different studies have used different cutoffs, but most of the time, if the thickness fraction is more than 30%, there are high chances that patient will pass the SBT, and if you will extubate, the chances of reintubation will be less. So once we have suspected that the patient is having failed SBT or the patient is having difficult or prolonged weaning, how to manage these patients? it is usually a multi-pronged approach we require, because the patient, as the more and more time is spent on mechanical ventilation, he will feel like he will not come out of mechanical ventilation. So he will require a good psychological support. In those cases, probably our psychiatric colleague can help, maybe counseling, good counseling. Then they will lose lots of muscle, and they will be lots of muscle mass loss and poor nutrition. There will lots of protein loss. So they will require a physical rehabilitation. The nutrition needs extra supplement, maybe high protein diet. They will require chest physiotherapy, because for long mechanical ventilation, many patients will have atelectasis. And then these are two things which are very important. Most of the time we keep on using sedation, which make patient comfortable, but we will also should understand that this sedation will have adverse effect on the neuromuscular system. So we should minimize use of sedatives, and sometime we may require tracheostomy also in difficult cases. So how to predict the weaning success? Actually, as Dr. Saurabh told, predicting the weaning success is very, very difficult, and this is more difficult in patients who are having prolonged or failed weaning, first weaning or difficult weaning. So in these cases, it's very, very difficult. The second problem is the mode of SBT, that how these patients should be given a SBT trial is not defined, whether we should do pressure support trial or TPs, and if these, for how long time the trial should be given. So we, in our department, we conducted a trial where we hypothesized that because these patients are probably more sick, they will require more time on SBT, and if they pass a longer kind of a prolonged time of SBT, they will be there are more chances of successful activation. So in this study, we compared 30 minutes versus 120 minutes of spontaneous breathing trial using pressure support ventilation in patients who have failed at least one SBT, means the patient who are having difficult weaning or prolonged weaning. So we screened almost 155 patients, and they 38 were excluded, and ultimately 119 patients were randomized, 16 in the short SBT arm and 59 in 120 minute arm. And what we found was the successful activation rate were no difference between two arms, whether it is 30 minutes versus 120 minutes. Similarly, all the secondary outcome related to successful SBT, activation failure, duration of ICU after admission, or duration of ICU stay after randomization, or duration of hospital stay, duration or ICU mortality, hospital mortality, day 90 mortality, all were comparable. So what that indicates? It indicates that irrespective of whether this patient are prolonged weaning or difficult weaning or simple weaning, we can continue with either 30 minutes or 120 minutes of pressure support spontaneous breathing trial, and they will fare equally with respect to all the outcomes, maybe reintubation rate or ICU mortality or 90 days mortality. Sometime, despite best of your effort, patient will require tracheostomy, and we know that tracheostomy will improve physiology. It increases the tidal volume, it will increase the maximum inspiratory pressure, expiratory pressure, it decreases the airway resistance, and also there are other positive effects also. But the confusion always remains, should we do it early or late? And the data till date is still controversial. So there will be various outcomes we are looking at after tracheostomy, whether there is a increase in weaning success, increase in ventilator free days, mortality or VAP rate. So there are few studies or even meta-analysis also which have shown that the tracheostomy increase the weaning success. There is more chances of patient will spend more time ventilator free, and there is some data which is not consistent one which shows that it decreases mortality and some VAP rate also. But these things we can see. Whether it is early or late, still the jury is not out. The reason being because many studies or different authors have used different cutoffs. The early definitely start from 7 to 14 days and sometime even 21 days also. So we don't know what is exactly early or late. So this is how we do weaning in our ICU. So this is what in most of the patient we will do. So once we think that patient is ready, so we will use this protocol, that first we will test the readiness using this criteria that the patient should improve from the underlying cause for which patient was intubated. We also check the oxygen status, hemodynamic status, and also the sensorium. Then if he is fulfilling these criteria, then we give a pressure support ventilation SBT. Usually these are the usual setting in most of the patient. We keep a pressure support of 0 to 5 and PEEP of 0 to 5. So this is the settings, and most of the time the duration varies from 30 to 120 minutes, but most of the time is approximately 1 hour, and we assess whether the patient is failing or successful. And during this trial, we assess with clinical assessment, which include the pulse rate, respiratory rate, the overall look. When we do blood gases, we also assess these indices. Sometimes we use these parameters, but most of the time these are not required. And then if they are successful, then most of the time, initially we were directly extubating these patients, but of late we are switching these patients back to mechanical ventilation for assist control for maybe 1 hour or so, and after that we are extubating them. In our ICU, because most of the patients are having underlying respiratory diseases, so many of these patients are extubated on either NIV or HFNC. Only few patients are extubated directly on low flow oxygen. Those patients who fail this, they are put back onto the maybe assist control mode, and we add sedation, and then we try to repeat SBT on the next day. So again we check on daily basis, and if we feel that the patient is having COPD, so many times these patients are extubated directly on NIV despite they are not fulfilling the criteria. And those who are not having this COPD or chronic hypercapnic respiratory failure, these patients are managed. We try to identify what can be the causes, maybe respiratory, cardiac, or any the psychological issues or nutrition issues. We try to address those, and then if they are fulfilling that criteria, and then we again give SBT. If they are successful, then we extubate. If not, then we plan tracheostomy, and usually we start thinking regarding tracheostomy at day 7. And if somebody is even maybe on day 10 or so, if we feel that this patient is not likely to come out, then we tracheostomize. But most of the time, by day 14, most of the patients will get tracheostomized. I think I will stop here, and I will ask Dr. Pawan Tiwari to explain how to manage post-extubation respiratory.
Thank you, sir. So basically, this peri-extubation period, so you've already seen how somebody who gets invasively mechanically ventilated gets extubated after passing an SBT. So this post-extubation period is very important, because this is basically the fruit of whatever efforts that we have put until this time. So this peri-extubation period is a crucial moment, and what happens is a lot of patients will develop post-extubation respiratory failure, and that is to the tune of 10 to 20% in patients who were properly assessed and had passed SBT. Now, this extubation failure has been defined in multiple ways, but by and large, it is basically re-intubation in the next 2 to 7 days after a planned extubation. The important thing here is that these patients who develop post-extubation respiratory failure are at risk of high mortality in hospital and also in the next 1 year, as the wages are already shown. And then there is increased risk of VAP and increased length of stay in the ICU as well as in the hospital. So these patients need to be monitored appropriately. And our target should be to prevent the occurrence of post-extubation respiratory failure. Again, in this cohort, it has been studied in a cohort of multiple ICUs across the world, and it was found that by day 90, with all and whatever protocols that we have used, we are able to extubate around 65% of the patients. And the median time to first weaning attempt was 1 day. That is when the patient was actually ready for SBT. But around 20% of the patients or more needed 5 days, and even then 15.6 had weaning failure. So this delayed initiation of weaning and higher sedation score, these are the important things which have been independently associated with weaning failure. Now, why this post-extubation respiratory failure actually occurs? Because what happens is, we were supporting the breaths of that patient, or the patient was on assist control mode, and there was he was a lot of times passive. So breathing was being generated by or supported by the ventilator per se. Now, what happens after extubation is that basically you have this change in the airway status. Then there is change in lung aeration per se. There are changes in hemodynamics, and there are changes in neuromuscular function. And all of this, like Dr. Saurabh showed you there, because of edema in the airways or because of upper airway complications of invasive mechanical ventilation, you can have upper airway obstruction.
Because of changes in lung aeration, you can have what we call as VQ mismatch or stunts or hypoxemia. Then changes in hemodynamics can lead to heart failure, either right or left heart failure, along with alveolar edema and decreased oxygen delivery. And all of this can actually lead ultimately to increased work of breathing. So our patient will have respiratory distress, increased rate and depth of breathing, air hunger, and all of that will then subsequently lead to this imbalance between the respiratory muscles' capacity to handle the respiratory drive of the patient and obviously the load. So all of this ultimately leads to what we observe, that is changes in our arterial blood gases, changes that is increased use of accessory muscles, paradoxical breathing, rapid shallow breathing, and all. And then subsequently this leads to post-extubation respiratory failure. So what we need to do is to prevent this. So one thing, so what are the strategies of ventilatory support after extubation which will prevent this? First thing is that you have properly assessed your patient prior to weaning. Now what will happen is, like Dr. Saurabh showed this and Vijay sir also did. So a lot of our patients actually will be extubated even while they fail the SBT. That is when these are those COPD patients or patients with chronic hypercapnic respiratory failure, which we kind of bring to a certain level of pressure support and then extubate them to the same level on non-invasive ventilation. So these are the patients in which we are using NIV to facilitate their weaning. So technically, they are not SBT successes, but this is called a facilitative use of NIV. The other is the most common scenario is basically when we extubate a patient after a successful SBT and then we give them either non-invasive ventilation using NIV or a high frequency HFNC high flow nasal cannula to prevent respiratory failure. And then the third subgroup, which is kind of difficult to manage, is those who have developed acute respiratory failure after extubation. So they are given therapeutic trials of NIV or HFNC, but that is a subgroup probably which we should keep a low threshold for again re-intubation. So this was basically done in our department. So this was high flow nasal oxygen therapy versus NIV in patients who are who pass an SBT for prevention of re-intubation in patients with hypercapnia at extubation. So the important thing here is that these are mostly patients who are hypercapnic and are at high risk of re-intubation. So this is a multi-center RCT. Basically, this looked at re-intubation rates within 72 hours after extubation, and then it also looked at treatment failure rates between the two groups and various secondary outcomes, which were clinical, ABG based, and also length of ICU hospital stay and mortality. And the preliminary results from one center, that is our center, has shown that basically both the groups were comparable in terms of differences between successful weaning outcomes, and that HFNC was actually non-inferior to NIV in prevention of post-extubation respiratory failures in this particular subgroup, which are at high risk of re-intubation. These were the different secondary outcomes. If you can look at, a lot of patients failed SBT, failed, I mean, these modes. So the important thing of failure was basically this device use continuation beyond the 48 to 72 hours. So if you can look at the NIV group, significant number actually kept using NIV for the duration more than 72 to 96 hours. But if you look at the HFNC group, so a significant proportion actually will need a treatment switch. So that is, if the patient who is on HFNC after extubation will have I mean, kind of failure of this post in prevention of post extubation respiratory failure, and will need a switch from HFNC to NIV. But in the NIV group, the patient will actually continue to use NIV for a prolonged period of time, but will have less of failure in terms of re-intubation. So this is what has been shown in different meta-analysis also. So recently this Korean guidelines for weaning had come, and in that they had done a meta-analysis of various methods of prevention of post-extubation respiratory failure. And when they looked at HFNCs versus conventional oxygen therapy, as Dr. Saurabh was showing, so weaning failure was reduced by almost up to almost 50%. But the important thing here is overall weaning failure reduces, but in the patients who are at high risk, there was no difference in re-intubation rates. Now, once we look at NIV versus conventional oxygen therapy, here we see that overall weaning failure, there is a wide confidence interval. So if you use NIV in patients without stratifying risk, probably it fares as well as conventional oxygen therapy. But if you look at high risk patients, here it definitely reduces weaning failure like odds of 0.3, and it reduces reintubation by almost 37%. So, so to say, basically HFNC will work for probably everybody, but if you have somebody who is at high risk of weaning failure, basically these patients who are chronic respiratory disease, those who are hypercapnic, those who have failed first SBT, who have chronic respiratory disorders, difficult diminished coughing reflex, post-extubation issues, higher age, heart failure, or were serious, had Apache more than 12 on the day of weaning or extubation. These are the patients where probably NIV fares better as compared to HFNC. And once you compare both of these modalities head to head, you see that practically overall they are almost similar in all aspects. But just to highlight the fact that so if any patient HFNC probably is better than oxygen therapy, and if patients who are at high risk of reintubation, like having these criteria, any of these criteria, probably NIV is better than oxygen therapy. So same thing was looked at again, and if you see here, basically for prophylaxis of prevention of post-extubation respiratory failure, HFNC and NIV both do very well overall. And then if you look at NIV, it works in these high-risk patients. In low risk, probably it is touching the midline, but in post-surgical patients and in high-risk patients. So post-surgical patients, HFNC fared better than conventional oxygen therapy, and in high-risk patients, NIV fared better than the conventional oxygen therapy for prevention of post-extubation respiratory failure. So this is an algorithm which was proposed by a review article. Basically, what we need to look at is once our patient is ready to be extubated, we should see whether the patient is at risk, is having risk factors for extubation failure. So subsequently, for these patients, we should have preventive strategies for high-risk patients. For low-risk patients, we can actually use HFNC or just use conventional oxygen therapy. HFNC is better, and for high-risk patients, we should choose NIV or HFNC depending upon individual choice, or like which modality are we more comfortable with or have more expertise. And one important aspect is in surgical patients. So here again, once they are extubated, you should look at risk factors for post-extubation acute respiratory failure, and then again consider preventive therapies. Overall, basically, it is said that that HFNC fares reasonably well, but if patients have high risk of failure, like they are obese, they have chronic respiratory disease, they have hypercapnia, then probably NIV will be a better choice. And all of these patients should be closely monitored for development of respiratory failure, and you should, once somebody has post-extubation respiratory failure, you should be very cautious in providing them HFNC or NIV as a treatment modality and have a very low risk of threshold for reintubation and resumption of invasive mechanical ventilation. So this has been actually studied in various, nowadays there is a lot of AI and everything. So this prediction of NIV failure has been studied in terms of machine learning and AI also. And they have actually formulated various kind of parameters, and they have these calculators which are available online and can be assessed for individual patients' risk of weaning failure or risk of post-extubation respiratory failure and risk of reintubation. So to conclude, weaning is the most crucial step, which is often delayed in this patients who are mechanically ventilated. Almost 65 to 70%, it will be simple weaning. So if you give somebody, if you assess somebody appropriately and give a proper SBT, you will be able to extubate that person on that day. So 65 to 70% will be simple weaning. That is the first attempt, is the successful attempt. Now 30% will have prolonged or difficult weaning. The pathophysiology, as discussed earlier, is complex, but we should try and correct the correctable or reversible factors so that we are able to extubate our patients. There is no definite validated protocol, but the important thing here is to have a protocol. So every ICU or anybody who is managing these patients on invasive mechanical ventilation should have a definite protocol to assess and to offer SBT and to wean their patients off invasive mechanical ventilation. And NIV and HFNC are very useful tools here, and if we use them judiciously in post-extubation period, then we may improve the weaning success. So here we will end, and I will invite Dr. Vijay to give his concluding comments.
Thank you, everyone. We thought that this topic is important That's why we brought it here. Because time is now just 5 minutes are left, so I will open the house for any comment or question.
During the presentation, it's not to emphasize the role of what first of all setting the records, and secondly, so before any site patient is not ready, that's where all look the aeration flow. There's one therapy, then you look at last two. We should first break the prediction, then we try. Then, secondly, what are and assess what is the amount. The patient has bleeding associated barriers, you are able to diagnose, right? Then you look at the abdominals and thoracitis. If there is a lot of ascites, it can push the diaphragm and your bleeding can be, bleeding can fail. So that is not very important. In fact, if you drain the ascites to start. Then the third is the muscle, like it was already mentioned, the muscle axon. And one of the two important muscles that you can see is one is the diaphragm that was mentioned, and second is the parasternal muscles. So parasternal muscle kicking fraction is a very important indicator of pain failure. So you can see that before you start eating afterwards. And finally, the use of accessory muscles. Right? So that all of these things will tell you whether the patient is ready to be weaned and whether the weaning is going to be successful or not. And secondly, having a protocol for weaning is an excellent idea. We should have a protocol in place. But above and beyond that, you should also have a clinical sense, the sense that, say, the patient comes in with a community acquired pneumonia, right? And or with septic shock, the patient is on basic pressors. Then the basic pressors are being out, the septic shock is dissolved, he's now ACS is normal. He has a very good cough, but his STD rate is still very high. If you calculate the RSPI, he does not fit into that criteria, right? But if he has a good cough reflex and he can, his condition is alright, you can take the water extubate the patient and put him on NIV, right? Because the dangers of keeping a patient intubated for a very long time is the patient is buying a bath, which is terrible. It increases the morbidity and mortality. And the choice of NIV versus HMC again depends on the patient and the condition. See, the patient has COPD and comes with acute exacerbation. It is always better to put him on NIV, right? But the bottom line being, the patient is able to clear the situation, the patient is mentation is normal, the patient is not delirious. If the patient is delirious, we will never accept from us. So in that case, you will have to resort.
Dr. Sajan.
As highlighted with that, and as rightly said, in these days we highly rely on HMSCs. But yes, for most surgical patients, HMSC was better, but for all high-risk patients, NIV is better. That is.
Dr. Weaning, what is your preferred protocol for weaning in your ICU? What protocol do you usually follow for weaning? Same?
We see the diaphragm, like,
So, whether you put a pressure,
diaphragmatic.
so you put the more, so start with pressure support, gradually reduction, or a straight to
So
TP?
it all depends on the diaphragm.
Kind of thing.
Sometimes we don't even walk the case, we straight away, when the patient starts getting alright, we not take 2 hours of case, and then straight away. And if the patient are being fair, the patient has a head and nothing from it. So obviously, after 48 hours, the critical illness associated with the sensitive, the patient is not never active enough. So there you have to see. You have to do something with the then obviously daily sedation, breaks you have to all right. So it all depends. But definitely, what we have then
I think it is ICU specific also, maybe kind of patient population.
yes.
Yeah, like our ICBC
most COPDs are destroyed, but it's probably we get more medical areas. So therefore, getting the experience would also be very critical.
But like one subset of patients like COPD with acute evaluation is probably common in both of our ICUs. That's why I mentioned.
I think those are the patients who are easiest to win from us. Otherwise, rest other patients are very, very difficult to manage, especially the patient with ILD.
Extubate the patient, put them on either an IV or a emergency. Monitoring, observation is the most important thing. So there is no use adults to or getting the emergency drugs in there. These are two things which you can use and assess the patient doing that. So that I think should be read by that that this patient need to be. It's not that you extubate the patient, put the patient on an IV and forget about it. The next 4 to 6 hours is most crucial, and if you have to intervene early to reintubate, it can save the patient. Otherwise, it can make a lot.
I think the overview of NIV post excavation period should not when you see that NIV is not working, patient is going down, you should intubate them in time rather than delaying it. And that is very common in lot of cases. Yes. Nobody asks. Intubation is delayed after an IV application, everything is, and then the patient gets intubated, and then has a plan. That should not happen.
So for every resident, I will suggest, I think 1 hour is the cutoff for post extubation. If patient is not improving in 1 hour, straight away intubate. In most of the patient, you will be saving the patient. If you are delaying more, then more chances of mortality. So this is particularly post extubation setting. In previous one, we usually 2 hours. If patient is coming to you, maybe in emergency or ICU, you want to give an IV trial or a HMG trial, maybe you can wait for 2 hours or so. But in post extubation, probably 1 hour is good enough. The second thing is ultrasound. I think nowadays ultrasound is being used for almost everything. And for weaning, lung, heart, and diaphragm. These three are considered a single unit to assess whether the patient will be successfully weaned off or not. So with that, I think if there is no other comment, we can close the session. Thank you very much.